Sir, I'm sharing the screen now. Please check whether you can see it or not. Sir, the screen is visible. Can you see it? Hello? Hello? Hello?
Good evening, my dear doctors. Hello. Good evening, my dear doctors. So today, hello, can I start? Hello.
Yes, sir. Please start. Please start.
Good evening, my dear doctors. Today, I have the honor to talk on approach to the management of interstitial lung disease. This is a very broad-based topic. You all know that interstitial lung disease are being seen in great numbers in the clinical practice. Many factors have contributed to this, including environmental pollution and also higher incidence of drug-induced as well as collagen vascular disease among the general population. May I have the next slide, please? May I have the next slide, please? Batul? Yeah. You all agree with me that interstitium is the space which is around the alveoli. We have 300 million alveoli in the adult lung, and they are supported by interstitial structures, which basically consists of the collagen matrix, lymphatics, and also the blood vessels and various cellular elements associated with these structures. So we have notably the alveolar capillary membrane, and then we have interstitial fibroblasts in the matrix, and we have alveolar type 2 cells, alveolar type 1 cells, which actually line the alveoli. We have macrophages, then we have the capillary endothelium, and then, of course, so these are the various structures which, in fact, become the anatomical part of the interstitium at the microscopic level. And now, interstitial lung disease. Next slide, please. Next slide, please. Yeah. So, interstitial lung disease means the disease which affects the interstitium, that is both alveoli, the terminal airways, the surrounding structures of the terminal airways, the alveoli, and the interstitial matrix that I have spoken about. So interstitial fibrosis essentially follows injury to the gas exchanging units. So alveolar injury increases the permeability of the capillaries, and there is exudation of fluid into the alveoli and also into the surrounding structures. So there's an inflammatory response, and there's a release of various pro-inflammatory, pro-fibrotic cytokines. And whenever there's inflammation, there is also a repair process which takes place simultaneously. So there's a regeneration reparative process at the epithelial and the endothelial surface, that is on the alveolar surface and also inside the capillaries. And when there is regeneration reparative process, so there is fibroblastic proliferation and there is excessive collagen deposition, which occurs in the interstitium, within the airway lumen and walls of the small airways. That means you have respiratory bronchioles, the terminal bronchioles, alveolar ducts, and so these are the structures which are affected whenever there is an injury. So there is inflammation and fibrosis. And this fibrosis is a relentless progressive fibrosis almost to the extent of being autonomous and almost to the extent of being something like malignancy. So, relentless fibrosis, even after having removed the antigenic uh, the stimuli, which is responsible for the injury. Next slide, please. Next slide, please. Batul. Yeah. So, the prevalence of interstitial lung disease varies from men to female, and men have a higher incidence as well as prevalence. So you can see on the screen that 80 for 1 lakh population for men compared to 67 for 1 lakh population for women. That's the prevalence. So the overall incidence, therefore, is higher among males. And the incidence also increases with their age. Men and women over the 75 years of age, they have a higher prevalence as well as higher incidence of the interstitial lung disease. Next slide, please. Now, when we talk of interstitial lung disease, there are 200 odd causes. What we see as idiopathic interstitial pneumonia, they're only the small part of the large spectrum of interstitial lung disease. And so majority of these cases are secondary causes. Connective tissue disorders constitute a large number of these cases. Scleroderma, polymyositis, dermatomyositis, systemic lupus erythematosus, rheumatoid arthritis, mixed connective tissue diseases, ankylosing spondylitis. They all cause actually excessive deposition of collagen in the interstitium. And they can also involve the small airways, they can have bronchiolitis, and consequently, you have the scar formation in these structures, and they have interstitial fibrosis. Similarly, there are a large number of drugs, including antibiotics like nitrofurantoin, sulfasalazine, then antiarrhythmic drugs like amiodarone, toconide, then propranolol, anti-inflammatory drugs like gold, penicillamine. Penicillamine, you all know it can cause the constrictive bronchiolitis, then chlorambucil, methotrexate, azathioprine, so carbamazepine, chlorpheniramine, they're all antineoplastic drugs, so they can all result in interstitial fibrosis. Radiation and oxygen toxicity because of release of superoxides, singlet oxygen, hydrogen peroxide. So they can all result in interstitial fibrosis. Then we have some primary unclassified diseases like sarcoidosis, primary pulmonary Langerhans histiocytosis, what is called the eosinophilic granulomas, amyloidosis, pulmonary vasculitis. Next slide, please. So, lipoid pneumonia, lymphangitis carcinomatosis, bronchial cell carcinoma. Earlier, they used to say interstitial lung disease means non-neoplastic and non-infective causes. Even the lymphangitic involvement due to sarcoidosis and then sometimes bronchial cell carcinoma, they all can present like interstitial pneumonia. Pulmonary lymphomas, Gaucher's disease, Niemann-Pick's disease, Hermann-Slipper syndrome, they're all congenital disorders with platelet deficiency and interstitial lung disease. Neurofibromatosis, lymphangioliomatosis, LAM, which is common in female in the age group of 20 to 40. So again, they can present with the breathing difficulty and hypoxemia. Tuberous sclerosis. So HIV, in fact, acute respiratory distress syndrome, HIV can present interstitial pneumonias, and bone marrow transplantation, post-infectious causes, eosinophilic pneumonias, alveolar proteinosis, diffuse alveolar hemorrhage syndrome. We have what is called the renopulmonary syndromes and the diffuse pulmonary hemorrhage syndromes. So they can all result in acute interstitial pneumonias, acute interstitial lung disease, alveolar microlithiasis, metastatic calcification. So we have a large number of causes. Next slide, please. Next slide, please. Occupational and environmental factors. So previous slide, please. So cold workers pneumoconiosis, berylliosis, they're all inorganic exposure. Inorganic exposure. But the most important thing in our setting in India is hypersensitivity pneumonitis, what used to be called the extrinsic allergic rhinitis. And the most commonest cause is these birds, the pigeons, the bird breeder's lung disease. Then farmer's lung, because of the compost and because of the fungal elements which are released, as a result of which silvophilus disease, the storage of the drains, and that can also can result in this fungus overgrowth, and as a result of which there can be hypersensitive pneumonitis. So organic causes are being increasingly recognized in the Indian setting. And when an end stage occurs, they almost mimic like our idiopathic pulmonary fibrosis. When there's end stage fibrosis, there's extensive honeycombing, and their behavior is something like you are is something like hello. Hello. Hello.
Yes, sir. The slide is there. Can you see it? Hello? Hello? Sir, the slide is there.
ಸ್ವಲ್ಪ ಲೇಟ್ ಆಗುತ್ತೆ ಒಂದು ಮೀಟಿಂಗ್ ಇದೆ ಹಲೋ ಒಂದು 10 ಗಂಟೆ ಆಗುತ್ತೆ ಓಕೆ hello. Some problem in the internet connection. You say some problem is there. I know it is a clinical approach. The mouse is has become unstable, and I am not actually fixed it. But no. But what is happening is that my mouse is moving up and down here. Yeah. So I'm not able to see the screen here. Yeah. You see, the mouse is unstable. I'm not able to fix it now. No, nothing. I'm able to see. Yeah, option is there, but I am not able to fix. Put my mouse exactly on that zoom and. Yeah, the laptop has issues. Yeah. Only thing is, what can I do? Unless I go to another laptop and get connected. Yeah. I will not be able. Can I do it? Say I will go to a nearby place. It will take 5 minutes. Is it okay? Okay, but then how can I talk? Can you hear me on the screen? Okay, but so what I would like to tell you is that we have large number of causes which are responsible for the interstitial lung disease, and majority of these cases are contributed by connective tissue disorders, hypersensitive pneumonitis, and which is basically extrinsic granulitis. Then we have pneumoconiosis, which are inorganic exposure, which can also result in fibrosis. And then drugs can also result in fibrosis. Then we have unclassified causes of interstitial lung disease. The numbers are increasing. I have told you that more than 200 odd causes are there for interstitial lung disease. And basically, what we have to understand that interstitial lung disease is a heterogeneous group of disorders with remarkably different prognostic and clinical histories. And most of these ILDs have interstitial inflammation, fibrosis. Idiopathic pulmonary fibrosis, currently viewed purely as a fibrotic disorder, is most prevalent. And this is in some series up to 20 to 50%. But in the Indian setting, as I told you, we have a large number of extrinsic allergic rhinitis, which present as hypersensitive pneumonitis, and as an end stage, they will have features similar to idiopathic pulmonary fibrosis with extensive honeycombing. And ILD has a very worst outcome, that is the interstitial lung disease of idiopathic variety, what is called the IPF, has a poor outcome at the end of 5 years, and it is lower than even the malignant disease. So IPF, idiopathic pulmonary fibrosis, is a chronic, progressive, fibrosing pneumonia of unknown cause. We don't know what exactly leads to this severe fibrosis, but they all have severe breathlessness, impairment of lung function, and then they have progressive respiratory failure, and they all die because of respiratory failure. Now, as I told you, that the prevalence of the disease I've already highlighted. It is more common among males than the female. And in those areas where you have an environmental pollution is there, then the incidence may be much higher. Now, basically, what leads to epithelial injury? There could be some genetic factors, we don't know. Maybe that they have a short telomere, or that there is some, a single nucleotide polymorphism in approximately half cases, and it is located in the promoter region of MUC5E, coding for the glycoprotein required for airway clearance. Then some of these may have short telomere length. So multiple genetic abnormalities have been detected, but not a single one which is responsible for this, the pathophysiology has been identified to say that it is a genetic defect. So the pathogenesis of the disease, why it progresses, is also not fully understood. So what is important is that there is a subclinical recurrent epithelial injury imposed on accelerated epithelial aging due to aberrant repair process. So this is basically an abnormal aberrant repair process. So there is relentless collagen deposition in the interstitium by myofibroblasts. So, and this this collagen is not removed. So there is also defect in the apoptosis. So oxidative stress, alteration of the telomere maintenance, all lead to co-fibrotic mediators. Now, so when we have to suspect idiopathic pulmonary fibrosis, we have to suspect in adults presenting with chronic exertional dyspnea, dry cough, or Velcro like tackles on medical evaluation. Typically, dyspnea and exertion is insidious, progressive, and over months or years. And by the time the patient presents, in fact, the patient has got an extensive disease. Early stage, the diagnosis may be missed. So, if you do a spirometry in these cases, you find there is a restrictive ventilatory defect. That means all the lung volumes are decreased proportionately, and the ratio of FE1/FEC is maintained normal. And all the flows, peak inspiratory flow, all the flows are appropriate to the reduction in the lung volume. Unlike asthma, where there is decrease in the airflow. Here, and also the ratio of FE1 oblique FEC is less than 70. Whereas here the ratio is maintained, airflows are appropriate to the lung volume reduction, and there is generalized reduction in all the lung volumes. And that is the hallmark feature of the restrictive defect, and also there is a diffusion defect. So the diffusion is prolonged in these cases. So there is a reduction in the TLCO, that is disproportional lung volume. This is also seen. And in early stages, the chest X-ray may be normal, and then or it may show non-specific findings. That could be reduction in the volume, the diaphragmatic border may be a little fuzzy, the cardiac borders may appear a little fuzzy, or there could be increased reticulation, interstitial opacities, reticular nodal opacities. And later, you may find what you call the cystic lesions coming up, and there could be some ground glass in the early stages, which suggests inflammation. So, the diagnosis of IPF, idiopathic pulmonary fibrosis, is challenging. So, it is a diagnosis of exclusion. That means we have to exclude the drug causes, exposure due to organic and inorganic dust. We have to exclude connective tissue disorders. Number one. And then the presence of usual interstitial pneumonia, UIP. What is usual interstitial pneumonia? That is extensive fibrosis. That is honeycombing, subpleural honeycombing is the hallmark feature of the usual interstitial pneumonia or the UIP pattern. Then we have what is called the NSIP pattern. That means there is a ground glass opacification. There is a ground glass opacification, but less of reticulation and cystic lesions. So they have more of a GGOs. So a person who has got the radiological features of UIP, and we have excluded the other causes of ILDs, then we can make a diagnosis of IPF. So the definite UIP pattern, synonymous with UIP histopathological pattern, consists of a bilaterally predominant basal and the subpleural reticulation and honeycombing. A probable UIP pattern is defined as bilateral, predominantly basal and subpleural reticulation associated with the traction bronchiectasis, but without honeycombing. That is a probable UIP pattern. A definitive pattern means there is honeycombing, subpleural distribution. So, in the correct clinical context, that is more than 65 years, no overt triggers of fibrosis, a probable UIP pattern is strongly suggestive of an underlying histological UIP pattern. Upper mid-lung predominance, subpleural sparing, cyst, mosaic attenuation, consolidation, excessive ground glass are typical of IPF and denote an these are atypical of IPF. If you have mid and upper lobe distribution, and that is more common in hypersensitive pneumonitis. Subpleural sparing, cyst, mosaic attenuation, consolidation, extensive ground glass. So they are more suggestive of NSIP pattern, and they are atypical of IPF and denote an indeterminate UIP pattern. So IPF can be diagnosed with great amount of confidence in the absence of a known cause for a fibrotic process when there is a definite UIP on CT scan in patients aged over 65 years of age. Probable UIP on CT. In other circumstances, clinical data, imaging are generally insufficient, and then we may have to go for bronchoalveolar lavage, and also we have to go for the lung biopsy. The bronchoalveolar lavage in these cases is useful in hypersensitive pneumonitis because we will have lymphocytosis, ball lymphocytosis. Ball lymphocytosis is a hallmark feature of hypersensitive pneumonitis that is due to exposure to organic dust. I told you the birds, the bird droppings, the bird feathers So they can all result in hypersensitive pneumonitis. So when you find a histological UAP pattern at surgical biopsy, that means you find the fibrotic focus, myelofibroblast, and cystic spaces. So extensive fibrosis, that is UIP pattern. So we have to have a multidisciplinary approach. That means in cases where surgical biopsy, thoracoscopy biopsy, or cryobiopsy by through bronchoscope, so that has to be decided. When the CT scan and the clinical features are not are very specific. So in such cases, one may have to go for a histological diagnosis, and that is where the multidisciplinary approach between the pulmonologist, the radiologist, the pathologist, rheumatologist, and the surgeons, they're all required. The treatment of IPF has evolved considerably during the last past decade. Of course, non-pharmacological approaches, smoking cessation, vaccination to prevent secondary infections like pneumonias, flu, supplemental oxygen for relaxation, physiotherapy, nutrition, respiratory rehabilitations. So, and treating the underlying comorbidities, they're all fine and they have to be done, no doubt about that. But then earlier we have used to use anti-inflammatory drugs, steroids, then immunomodulators like cyclophosphamide, azothioprine, so mycophenolate. So these drugs have been used earlier in the treatment of IPF. But then the studies have shown that when you use these drugs, it is associated with a higher mortality. So there is a strong recommendation given in guidelines against the use of prednisolone in combination with azothioprine and N-acetylcysteine due to major increase in overall mortality and respiratory hospitalization in controlled trial. So the present status is that in case of IPF, who have a UIP pattern, use of steroids in combination with cyclophosphamide or azathioprine and N-acetylcysteine is associated with increased hospitalization and also higher mortality. To date, two medications have been recommended, that is antifibrotic tyrosine kinase inhibitors. We have pirfenidone and nintedanib, and they have been approved and show some safety and efficacy in a placebo-controlled randomized controlled trials. Both slow the rate of FVC decline. Both these drugs, pirfenidone and nintedanib, slow the rate of FVC decline by 50% over 52 weeks. Nintedanib also appears to reduce the rate of the acute exacerbation. No reduction of mortality has been approved in RCT, but pooled analysis suggests a reduction in overall mortality in IPF. So, nintedanib is a tyrosine kinase inhibitor that targets the multiple growth factors pathways, the vascular endothelial growth factors, fibroblast growth factors, platelet-derived growth factor. So, in other words, it has got antifibrotic activity at various levels. Side effects, of course, include diarrhea, which can be controlled with anti-diarrheal agents. Pirfenidone has various anti-inflammatory and anti-fibrotic properties. It downregulates the pro-fibrotic factors, reducing the fibroblast proliferation. Side effects again, anorexia, nausea, vomiting, and a photosensitivity rash. Liver function should be checked, tested at baseline, and they have to be monitored regularly with both the drugs. And recommendation of one agent over the other cannot be given. No head-to-head data are available. The efficacy of combination treatment has yet to be validated. So patients of acute IPF can have exacerbation. That means there is an acceleration in the disease over days to weeks that leads to significant decline in lung function, and they can present with acute respiratory failure. So that is a diffuse cellular damage, what was the diet, superimposed on the fibrotic lung. So, what is the criteria? Previous concurrent diagnosed IPF, unexplained worsening of dyspnea within past 1 month, new bilateral groundless opacification or consolidation on chest HRCT. And we have to exclude cardiac failure. Mortality is very high, 60 to 80%. Okay. No current treatment has proven efficacy. Even then, high dose corticosteroids associated with broad spectrum antibiotics are widely used as recommended as a treatment of acute exacerbation of IPF. So, now, nintedanib, is used in the dosage of 150 milligram oral 2 times per day, and pirfenidone 600 to 800 milligram oral 3 times a day. And we have to regularly monitor LFT in case of pirfenidone, and bleeding risk anticoagulants should be avoided with nintedanib. So this is as far as the treatment of the IPF is concerned, and ultimately the final treatment is lung transplantation. Those who have extensive bilateral UIP pattern, and and then who have the Bose index is 7 or 8, and so these are the cases where we have to actually enroll them for the transplant program, and transplantation, there's a waiting time, and transplantation is the only final answer in these cases. So, ladies and gentlemen, there were some issues in the slide presentation because of some problem in the net, also in the laptop, and as a result of which I could not have an one-to-one contact presentation, and also I could not go through the slides which I had prepared meticulously for the occasion. But having said so, what I would like to tell you that today's topic is essentially a generalized approach to the management of IPF. So the approach to the management of IPF is that first of all, we should diagnose that the person who presents with breathlessness and progressive coughing, we should diagnose them to have ILD. Interstitial lung disease means they have an interstitial pneumonia, so they present with breathlessness and cough, and they will also have hypoxemia. And if you do an X-ray, they have an interstitial pattern. So it can be acute presentation, it could be subacute, it could be chronic presentation. And X-ray shows reticulation, reticular nodular opacities, cystic lesions, honeycombing, and also there is loss of volume. And it may be associated with the carpulmonary, and therefore they may have features of pulmonary hypertension also. And CT scan is the one which actually detects the disease in early stage when the X-ray may be normal, and the clinical symptoms may not be there at rest. Some of these symptoms become overt on exertion. Otherwise, at rest, they may have a normal, they may not have symptomatic. So, those cases who have exertional dyspnea and who are in that age group, actually one should suspect interstitial lung disease, and they should be investigated. And we have to take a detailed history, and we have to exclude the secondary causes because they constitute majority of cases. Maybe 50 to 70% of the cases are secondary causes. The secondary causes, as I told you, are collagen vascular disease, inorganic dust exposure, organic dust exposure, and exposure to various drugs. And then we have sarcoidosis, tuberculosis, and different types of, interstitial lung disease, and they can all result in ILD. So we have more than 200 odd cases. In about 20 to 50% of the cases, especially in Western world, we have what is called the idiopathic pulmonary fibrosis, IPF, and this IPF has got a typical pattern, what is called the UIP pattern. The UIP pattern is one where is subpleural distribution, honeycombing. And NSIP pattern is one where you have ground loss opacification and there are hardly any cystic lesions or honeycombing. And CT scan will definitely tell us whether you have a definitive pattern or a probable UIP, or but then if there's a distribution in mid zones and upper zones, they're not subpleural, and then they don't have honeycombing, they have more of consolidation and a more of ground classification. These are the points against the UIP pattern. Now, if there is underlying lung disease like collagenous vascular disease, they have to be treated. And remember that many times they may not have the systemic manifestation of collagen disease. They may present primarily as a pulmonary problem that can occur in some of these cases. So all these cases of ILD, therefore, we should do a workup for any collagen disease, whether it's a rheumatoid arthritis, mixed connective tissue disorder, scleroderma, or systemic lupus erythematosus. So this condition should be kept. And hypersensitive pneumonitis, collagenous vascular disease, actually we have certain, the blood changes will be there. Then we have markers will be there. And if you do the bronchoalveolar lavage, then you may have lymphocytosis in case of hypersensitive pneumonitis. And we have macrophages which are the with the lipids and all, maybe there in certain drug-induced, ILDs. So lavage and biopsy histopathology will also help us to make to exclude the secondary causes. And if you do histopathology in so-called indeterminate UIP pattern, in such cases, if you are able to demonstrate the honeycombing and also the myofibroblasts and excessive collagen, then the diagnosis is certain. So we have to have a clinical, radiological, and a pathological correlation. And once we make a diagnosis of IPF, in such cases, the only drugs which have been proved to be useful is antifibrotic drugs. It is not the N-acetylcysteine or the steroids or, for example, azathioprine, which used to be the drugs which used to be at about a decade ago. The large number of cases used to be given these drugs. But controlled studies have shown that they are associated with higher mortality and also they require a more number of hospitalization. And therefore, these drugs are no more recommended. The only two drugs which have been recommended as of now is pirfenidone. The other one is nintedanib. Pirfenidone can be associated with photosensitivity and epileptic derangement, and the nintedanib is associated with GI side effects. And these drugs have to be given on a long-term basis. They actually stabilize the condition. A long-term mortality benefit may not be there, but they reduce the exacerbation, a requirement of hospitalization, and also the steady decline in the lung function to some extent may be retarded by these drugs, but they require to monitor for the side effects. And those cases where the disease is progressing, the only treatment which is option is lung transplantation, for which there is a waiting time, and that's the only definitive treatment as far as the IPF is concerned. And finally, one should also focus on respiratory rehabilitation, on the nutrition, and also the treatment of the comorbid condition, oxygenation, and the treatment for pulmonary hypertension. And remember one thing, that some of these cases may have GERD, gastroesophageal reflux disease, which may be the silent cause of relentless fibrosis, causing the epithelial injury to the alveolar epithelium. So microaspiration on long-term basis is also one of the reasons why they may have what is called the IPF. So all these factors have to be considered. And the most important as a practitioner is that diagnose the condition. Don't treat them like, TB or asthma or COPD. A definitive diagnosis is extremely important. And then whatever supportive treatment possible, it should be offered to the patient. And then in those cases where lung transplantation is possible, one should try that option as well. So, ladies and gentlemen, I've finished my presentation, and well, uh, uh, I'm sure you may have a lot of questions, but if there's any questions, of course, they can, you know, uh, the the mediator and the compare can, you know, convey to me on phone, and then I will be able to answer them. Okay, thank you so much. Hello.
Thank you so much, sir. Hello. Yes, sir.
I finished my presentation. Was it heard? Okay, if there's any questions, they can ask me and I will try to answer them.